Having discussed all the basics of red blood cells, let us go forward and talk about microcytic hypochromic anemia. By now, all of you know what are the indices and when do I give the definition of microcytic hypochromic anemia. So we can start straight away with what is the mnemonic that we shall be learning for microhypo. First and foremost, we have sideroblastic anemia that comes under it. So sideroblastic anemia is a microcytic hypochromic anemia. Then we have the most common anemia in our country, that is iron deficiency. Then we have the thalassemias, which are microcytic hypochromic, and we have a disease called anemia of chronic disease. Now, anemia of chronic disease is a little bit different because this can have two different types of morphologies, means it can be normocytic normochromic also, and it can be microcytic hypochromic also. So repeating, it can be both normo and microhypo. Although right now I'm telling you under the Sita mnemonic as microhypo, but let me tell you, it is more commonly normocytic normochromic, and that is the question that you get. So repeating, microcytic hypochromic anemia is a Sita mnemonic, sideroblastic, iron deficiency, thalassemia, and anemia of chronic disease. I'm starting first with iron deficiency because this, as all of us know, is the most common nutritional deficiency that we have in the country, right? The most common nutritional deficiency. Gradually we'll come to all of them, but yeah, for the time being, let us know about this. This is the most common nutritional deficiency. Let's get going. When I talk about iron deficiency anemia, they are not very much interested in the anemia in the exam. They are more interested in about iron transport, metabolism, and all of those. So first I'll tell you everything about iron, and then I'll come to the deficiency part of it. So first thing that we need to know is about iron metabolism. So please remember, what is the site of iron absorption? From where does iron get absorbed? So the most important absorption site is the duodenum. I think this is a question you read in your systemic path also. Site of iron absorption is going to be the duodenum. And what is the form of iron that I'm talking about? So if they ask you what is the form of iron that you have in the food, and this is usually a kind of Fe3+ iron in the food. But what is the form of iron that I will use for absorption? Which is the form of iron that my body absorbs? And that is Fe2+. So can you see that I will need one step? I will need some helper who will help me convert the Fe3+ in my food into Fe2+ so that I can absorb it in the duodenum. And I will tell you in a while who that helper is. So the form of iron in the food is 3+, but what I have to absorb in the duodenum is going to be 2+. Then when I'm talking about the food, please remember, food iron is of two types. There is something known as heme iron, and the next is known as non-heme iron. When I say heme and non-heme, means one of them is vegetarian and one of them is non-vegetarian. So only one non can come in the story. If the non has come over here, non-heme, then I can't say non-vegetarian. I will have to say vegetarian food. And if there is heme iron, abhi tak no non has come, so now the non can come. This is seen in non-veg food. So please remember, only one non allowed in the story. So if it is heme iron, then it is non-veg food. And if it is non-heme iron, then it is going to be vegetarian food. This is your basic of the iron forms that you have. Now let's start with how iron is going to get absorbed. Before I start with that, there are some basic definitions that you should be knowing, that how is iron or metabolism going to get affected. So basically, when I'm talking about iron absorption, what are all the things in my body which increase the absorption, and which are all the things in my food and my diet which can decrease the absorption? Very simple way of learning it. All the acid things will increase absorption. Means if they say that there is an acidic pH, if there is an acidic pH means what? Who creates acidic pH? Hydrochloric acid, right? Other than that, one more acid, amino acids. Amino acids have to be in abundance. Which vitamin? Ascorbic acid. Another acid added. Ascorbic acid matlab vitamin C. So that is why you must have heard that vitamin C tablets are very commonly given along with iron tablets, because they help in absorption of iron. So remember, anything to do with acid, and acid. All the acidic things are going to increase the absorption. Whereas if I make anything alkaline, means I talk about alkaline pH, or milk, or some molecules that are present in food items like phytates and tannates, and these are very commonly also seen in tea and coffee. That is why they say that you should never have your morning cup of tea and coffee along with iron tablets. Never take iron tablets with tea, coffee or milk. Why? Because they all tend to decrease the iron absorption. So repeating, there should at least be a 30-minute gap between if in case you've had any tea, coffee. So repeating once again, all the acid and acid things increase the absorption, and everything that is alkaline, milk, tea, coffee, phytate, tannates, they are going to decrease the absorption. This part is clear? Next. How does iron transport in my body weight? So what is the transportation form of iron? Very simple. I'll take the trans from here and I'll take the iron from here. Means the trans is going to be trans for trans, and iron ke liye we say ferrin. What is the transportation form of iron? It is known as transferrin. Please remember, if this is a transferrin molecule, this is one transferrin molecule, how many parts of iron can it bind to? God has given it 1, 2, 3, 4, 5, 6. Ideally, that is what I'm telling you. One transferrin can bind to 6 molecules of iron, but that is an ideal situation. Practically, that doesn't happen. For example, if you're traveling in a metro, if you're traveling by public transport, there are 6 seats in a metro. Will you want to go and sit back to back? If someone is sitting here, for example, someone is sitting here, what is our usual preference? Will I want to stick to that person and sit over here, or will I do social distancing and sit after one seat? Everyone sits by leaving gap until and unless it is a peak time and then everyone has to get cluttered together. But I always try that I keep one seat empty, vacant, and then I sit on the next. That is what happens. So practically what happens is that so many irons cannot sit over here. Practically only 2 irons decide to sit. One transferrin can bind to 2 molecules of iron. So tell me something, what was the total capacity of iron, of transferrin? The total capacity was 6 seats, but how many got occupied? 2 got occupied. So what is the total percentage occupied? 33%, and that is the definition of transferrin saturation. They will ask you, what is the normal transferrin saturation? The normal transferrin saturation is a 33%, and you understand how did I calculate it? There were 6 sites available, but only 2 got occupied, so the total transferrin saturation comes out to be a 33%. Very, very, very important. But now, these are transferrin. This is a transferrin molecule. And has it gotten bound to iron? Perfect. So here you have a transferrin and here it is bound to iron. Transportation is going to happen to what? The purpose of transporting iron, where do you want to, what is its final destination? Where do you want the iron to go? So for example, this is your transferrin and this is your iron ka combination. Where is it that you want to take it? You obviously want to take it to the bone marrow. Why do you want to take it to the bone marrow? Who is waiting over there? Who are the cells which need iron, which have to make hemoglobin? These cells are going to be the erythroblasts. The erythroblasts are waiting for iron, that when will I get iron and when will I be able to use all that iron for taking up my, making my hemoglobin. So can I say erythroblasts has a lot of transferrin receptors? Can I say the transferrin receptors are going to be there because they will be able to come and bind over here. The transferrin and the iron will come and bind over here. So there are a lot of transferrin receptors. So tell me something. Who needs more hemoglobin to start the production? The early blasts or the late blasts? I realize that there is increased transferrin receptors that are present on the early erythroid precursors. On the early erythroid precursors, because in early stages you need more of hemoglobin production. More of hemoglobin production means you will need more transferrin, more iron, more receptors. So in the early stages of the blasts, the transferrin receptors are more. And as we go on to the late stages of the blast, for example, the late normoblast, by that time most of the hemoglobin is made. When most of the hemoglobin is made, can I say the cell will say, now my hemoglobin is made, now I don't need any iron, let all of it go. Is it going to release all of its transferrin receptors? Is it going to release all of its transferrin receptors? Let's do a very, very quick recap of all of this. Please note that this transferrin is roaming around with iron. It is roaming around in my blood, and where is it going to finally go to? It is going to go to the bone marrow. Because in the bone marrow, someone is waiting, and that someone is the erythroblasts. Early erythroblasts, intermediate erythroblasts, late erythroblasts. Yaad hai na? Everyone remembers? The early ones are saying, okay, jaldi, jaldi, give me a lot of iron. I need iron. I need to make hemoglobin. So they have lots of receptors on their surface. Lots of receptors. But as this cell becomes a late normoblast, which says, now my iron, now my hemoglobin is made. Now I have good amount of hemoglobin. Now I don't need hemoglobin. So now let these receptors move out. Can I say the receptors have been released? Where have they been released? They have been released into the blood. So can I say there will be an increase in the serum levels of transferrin receptors? And that is what you see as a marker of erythropoiesis. That is a question that we get in the paper. Please note this question in as bold as possible. Please note, if they ask you which of the following is considered as a marker of erythropoiesis, and that is going to be increase in serum transferrin receptors. Why so? Because that means that if the transferrin receptors are increasing, this means more and more cells are forming, more and more hemoglobin is forming. So it is a marker of erythropoiesis. Very, very, very important question, and I hope everyone's understood it. What have you understood? You have understood everything about the transport form. You have understood everything about transferrin. You have understood the normal saturation is 33%. But what is the storage form of iron? That's the next question. The storage form of iron is different. Very common confusion that happens among students. The storage form of iron is ferritin. Don't get confused between these two, please. If they ask you what is the transportation form of iron, that is transportation for that is transferrin. How is iron stored in the body? Iron is stored in the form of ferritin. All your basics of iron are done. Quick revision, 5-6 questions. Let's finish it off. Question number 1. What is the site of absorption of iron? It is duodenum. Which form does duodenum absorb? Fe2+. But what form does the food have? The food has Fe3+. Next question. What are the things that increase the absorption? All acid things increase the absorption, or alkaline milk, tea, coffee, phytate, tannate, they decrease the absorption. What is the transportation form of iron known as? It is known as transferrin. What is the storage form of iron known as? It is known as ferritin. What is the normal transferrin saturation? It is going to be 33%. Okay, what is a marker of erythropoiesis? It is increase in serum transferrin receptors. All sorted. I am finally ready with all my definitions to study the absorption of iron. So what am I going to do for that? For that, I will have to make a cell. Why am I making a cell with these villi? Because as soon as I start making villi, I do understand that, yeah, there is some element of intestine that I am talking about. Hai na? And what cell am I talking about? Which part of the intestine? There is a duodenum. Duodenum ka this villi, so this must be the apical surface. This must be the basolateral surface. So there's an apical surface, means towards the lumen where the food will come, and then there's a basolateral surface, that is a duodenum cell. And here you have your food with iron. Food has which kind of iron? Food has Fe3+ wala iron. But can I absorb Fe3+ iron? No. What will I have to change it into? I will have to change it into Fe2+ iron. Did you ever wonder why? Why has this discrimination being done that Fe3+ to nahi absorb karna? Fe2+ I will absorb very, very easily. Anyone thought over it? Because there is a person over here which has to absorb the iron. Please note, there is a person over here who has to absorb the iron, and the name of that person is very, very important. DMT1 transporter. That is known as DMT1 transporter. Do you know the full form of DMT? Divalent. Now that tells you the valency. What will it allow? Divalent metal transporter. Which kind of metals does it allow? It always allows the 2 valency wala. 2 valency. So what all will it allow? Fe2+ or 3+? Now you've got the concept. It will only allow Fe2+ to pass through it. That is why I have to change it. It will allow everything with 2. It can allow magnesium. Magnesium has 2 valencies. Manganese has 2 valencies. Copper can also have 2 valencies. Iron can have 2 valencies. Everything 2 to 2 will go via DMT. It will allow all the metals with two valencies to pass through it. So now you understand the reason for changing your Fe3 plus from food into Fe2 plus. How do you do that? There's an enzyme that is known as cytochrome B reductase. There is an enzyme known as cytochrome B reductase and the conversion has happened, and via DMT1 you have got your Fe2 plus inside. But did you want to keep it in the duodenum? No, the purpose is, where do you want to send the iron? End result, end destination kya hai? The end destination is, there is a bone marrow waiting for iron to make hemoglobin. Bone marrow needs iron for making hemoglobin. So finally you have to send it there. So time to bring it in the blood. Time to bring this iron into my bloodstream. How do I bring it into my bloodstream? I'll draw one big blood vessel over here. And how do I bring it into my bloodstream? Because I am now going to have another marker over here, or another port over here, which is known as ferroportin. This is one of my favorites because it's the easiest to analyze. What is this known as? We'll do it once again. This is known as ferroportin. Dhyan se sunna. What did I say? Ferro because iron, port because it's a channel, and in because it is bringing it inside my body. So remember, ferro for iron, port for channel, and in for bringing it inside the body. Fe2 plus has finally entered inside the body. Where? It has entered into the blood vessel. Now please note, I did a trick over here. I did some trick over here. I tried to act smart. Ideally, I never need iron in Fe2 plus, neither for my hemoglobin nor for anything else. But only because this DMT over here had kept a condition that I will only allow 2 valency wala person to enter. So I had to change it into Fe2 plus. Now that step is gone. Fe2 plus has come in. Fe2 plus has come in via ferroportin. Now do I need to keep iron in Fe2 plus form? No. So now I'm going to act smart and I'm going to convert it back into Fe3 plus. And how do I do that? There are 2 molecules available. One is known as ceruloplasmin and the other is known as hephaestin. One is ceruloplasmin and the other is known as hephaestin, and this Fe3 plus iron is then going to be binding to who is the transport molecule? Who is the transport molecule, guys? It is transferrin. So this Fe3 plus then combines with transferrin, the transport molecule, and goes all the way to whom? Goes all the way to the bone marrow. That wraps up your iron metabolism. A 30-second recap. Jaldi se. We have Fe3 plus in the food, but we can't absorb that mostly. We have to convert it into Fe2 plus via which enzyme? Cytochrome B reductase. Why Fe2 plus? Because there is a metal transporter here which only allows 2 valencies to pass, divalent metal transporter. So 2 valency wala iron enters, and after that I have to get it in my blood because I have to give it to the bone marrow. To get it in the body, I need a port for iron. Ferroportin is what I need it. Iron has come in. It is going to convert back into Fe3 plus by what 2 molecules? By ceruloplasmin and hephaestin. And that Fe3 plus then goes with transferrin all the way till the bone marrow. Very good. This is seeming so nice. But do you know one more thing? This ferroportin, which was so nice, where did you see them? At which part of the duodenum? At the apical part or the basolateral part? Aisa question aayega. It is present on the basolateral part. Let me tell you, that's not the only place where it is present. Ferroportin is present not just in the duodenal cell. It is also present in the placenta because there also iron is needed. It is also present in the macrophages of the bone marrow. So remember, the bone marrow macrophages also, don't you think the bone marrow macrophages also have to give iron to cells? Then placenta also needs iron. Duodenum also has to get iron in. So wherever you want to give iron inside the body, you will use ferroportin. So ferroportin is present in macrophages, placenta, as well as the duodenal cells. This one chart is very, very important. But now comes the next point. I have to highlight and zoom into this portion over here. Means what? I have to highlight and zoom in that, okay, iron and transferrin have gone all the way up till here. But whom is it going to go to? It is ultimately going to go to which cell in the bone marrow? The erythroblast. Okay. So what I'll do over here, I'll draw one transferrin. That transferrin has these molecules of Fe3 plus that are roaming around with it. And this ultimately has to go to an erythroblast who is waiting that, oh, when will you come and I will make iron out of it. I will make hemoglobin out of it. This erythroblast is waiting. Ye erythroblast ka nucleus hai. Why in red blood cell pathogenesis am I talking about nucleus? Because blast mein to nucleus hota hai na, right? So there is a nucleus that is present over here, and very nicely, now I say this transferrin and iron has reached the bone marrow. Which is the receptor that is going to be present over here? The story that I was telling you earlier, the transferrin receptors are present. Do you agree? Okay, the transferrin receptor says fine, this entire thing is going to be engulfed. ये जो जितना भी है ना transferrin and iron and everything, इसे पूरा as it is just engulf it, just eat it up. This is known as an endosome. This is known as an endosome. So what have I done? I have engulfed the transferrin, and along with the transferrin, I have engulfed the iron and the iron. But do you want to keep both of them attached? No, I am only interested in iron. Iron alag karo. So now what do? I separate the iron. How do I separate? How am I going to make iron and transferrin dissociate? To make iron and transferrin dissociate, I will have to decrease the pH. Please remember, the endosome has to be acidified. The endosome is acidified because as soon as I will decrease the pH, break up. Simple. Initially, transferrin and iron were strong buddies, but as soon as I ate them, as soon as this erythroblast of mine ate it, break up kar diya. Kaise break up kara? By creating an acidic pH, and now this iron is free. Now this iron, majority of this iron is going to be used for what? Will be used for hemoglobin production. 90% of the iron is going to go to the mitochondria, because where does heme production? Go back to your biochemistry. Heme, protoporphyrin, heme, wo kahan hota hai? 90% of it is going to be used in the mitochondria for hemoglobin, and 10% of it shall remain in the cytoplasm. 10% of it shall remain in the cytoplasm. So please remember over here, very, very important situation that I have come back to. So repeating, transferrin has come, it has gotten bound to transferrin receptor, it has been eaten up, engulfed as it is. Then I realized, pura to I have eaten, but I am not interested in transferrin, I am only interested in the iron part. Let me just pick up the iron wala part, and the iron wala part is supplied to whom? The iron wala part is supplied to mitochondria, because there is where the hemoglobin production is happening. That wraps up your final destination also. This is very, very important. So now your hemoglobin production is done. You are happy. Iron has been utilized. However, who is the mastermind behind all of this? Who is watching very quietly? Mastermind is always someone who will not come in the entire story, but will come right in the end, and there'll be a change in the plot. Who's the mastermind? Someone who's not spoken about up till now, and that mastermind is hepcidin. That mastermind is hepcidin. So remember, if they ask you what is the source of hepcidin, where has this mastermind come from? Hep word tells me it is coming from the liver. It is coming from the liver or hepatic. Next, they'll ask you what is hepcidin. So mastermind, always consider this as hijacker. I have always called hepcidin as hijacker. If someone hijacks your house, will he let you move out of your house? No. Will he let you use your money in your bank account? No. Will he let you eat, sleep, do anything? Nothing. Hijacker matlab life is hell. So what is hepcidin going to do? What is its function? What is this mastermind going to do? In matlab inhibits everything. Firstly, whatever you're eating, you say that, okay, I'm eating a lot of iron, ma'am. But will hepcidin let you absorb that iron? No. Inhibits. It inhibits iron absorption. It inhibits iron absorption. Okay, so it's pretty bad. I'm eating so much of iron, but it is not letting me absorb any iron. Firstly, why is it not letting me absorb any iron? If I go all the way back to my pathogenesis, where is it acting? Here, 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 here. Where is it not allowing me to absorb the iron? Remember, it is acting at this step. Which is the thing that it is inhibiting? It is inhibiting ferroportin. So how does hepcidin not allow me to have any inhibition or any iron absorption? It inhibits ferroportin. Previous year question, very, very important. Coming to the next part, what else is it going to do? You'll say, okay, iron I'm eating, it's not letting me absorb. What should I do? I'll ask for some help from my stores. What is the storage form of iron? Ferritin. You say you go to your bank, your storage, your bank, your ferritin. You say, listen, can you lend me some money? Can you lend me some iron? But will a hijacker let you use your bank account? No, na. So will it allow you to release iron from ferritin? No. It inhibits that also. It inhibits the release of iron from ferritin. It inhibits the release of iron from ferritin. Repeating once again, what does hepcidin do? Hepcidin is hep, means it's coming from hepatic, it's coming from the liver. What does it do? It is going to inhibit the absorption of iron also. How? By acting on ferroportin. Second, it is going to inhibit the release from the bank account also. So it's like, you've heard a saying, water all around, but not a drop to drink. Same way, there is iron all around, but not a drop to use. There's iron in your food, but I cannot absorb it. There is iron in my bank account, but I cannot use it. Iron all around, not a drop to use. And that is what hepcidin does for me. This is the master regulator. On that note, I have finished the entire iron metabolism for all of you, which is very, very, very important. So don't miss out on it, okay? Once you've done the iron metabolism, you are now ready to go ahead with the deficiency part. Iron deficiency anemia, which I was telling you is the most common nutritional deficiency over here. In India, the most common nutritional deficiency anemia that you have is going to be iron deficiency anemia. And what are the causes? Think logically, in our country, ya to someone is not having good amount of iron in the diet, or there is someone who's had an increased demand of iron. Increased demand would be in which situation? Either I'm dealing with a female who's pregnant, so during pregnancy, or she's lactating, so lactation, or it is a growing child in the early days, in the puberty days. So these are the times when the body requires more iron and is not getting it, so because of an increase in demand. Second, maybe someone is having increased blood loss. Maybe someone is having increase in the blood loss. So why is blood loss? Let me tell you age wise, ठीक है? तो blood loss क्यों हो रहा है? Think logically. Maybe there is a child and maybe that child has had some parasitic infection. So which parasitic infection can you correlate with this? This can be very commonly correlated with hookworm. Iron deficiency anemia very commonly correlated with hookworm. So because of that there is bleeding happening, okay? Or even if not bleeding, but hookworm की वजह से iron deficiency anemia होता है. Then this is a chota bacha. Hookworm is seen in chota bacha. Let's talk about adults. Anything that you can see in adults with regard to the stomach, peptic ulcer disease. Does peptic ulcer disease bleed? Will the person have blood in the vomitus? Yes. Next, let's go a little forward. What you have a very, very old person. Very, very old person means colon cancer. Colon cancer, does it cause blood loss in the stools? Yes. So देखो, या तो very, very छोटा बच्चा होगा with hookworm infection, or an adult with peptic ulcer, or a very, very old person with colon cancer, or simply a female with heavy menstrual bleed, HMB, heavy menstrual bleeding. So menstruation related problems in females are going to also result in a lot of blood loss. Lastly, what is the site of iron absorption? Duodenum. So if there is any duodenal or intestinal disease, can you think of a disease which you've studied in systemic pathology and in medicine where the patient has iron deficiency anemia? Which disease affects D? Remember, diarrhea wala disease tha, duodenum effect tha, deficiency anemia. We were talking about the very famous celiac disease. And if you remember, this is a question that I told you, that although celiac disease is an intestinal disease, it causes D for diarrhea, D for duodenum. And if duodenum is affected, iron will not get absorbed. That is going to result in iron deficiency anemia. So let's do a recap. What are the reasons why someone will have iron deficiency anemia? Either there's a decrease in the diet, or there's an increase in the demand, or there is some or the other route of blood loss mentioned, or if there is any duodenal disease, because duodenum is the main site of the absorption. But which infection in microbiology will they tell you? This is hookworm infection, right? So whatever may be the reason, iron deficiency has started. So what are the stages of iron deficiency anemia going to be like? Please note, this occurs in 3 stages. Iron deficiency anemia occurs in 3 stages, that is stage 1, 2 and 3. So please note, stage 1 is when only, so for example, but if you ever end up, start getting, which all of us have experienced actually, hostel mein, on 1st of every month when we get money from home, we are very, very rich. And by the end of it, by the end of the month, by 30th, we are very, very poor. So that is something which has happened to all of us at one point of time, and that will never happen once you get NEET PG and a seat of your choice, because you get a stipend. Okay, so some positive vibes for you to get going and some motivation for you. Okay, on that word, initially, What happens when we are in a major money crunch? What happens? First we realize, the bank account is, I'm seeing my savings are somehow depleting. I'm not having a good bank balance. So the first stage is a stage of decreased storage. Mainly by basically I'm very worried that, वैसे तो ठीक है, everyday work I'm doing, but my bank account doesn't have so much of money. Basic concept is that there is a decrease in bank account means ferritin. There's a decrease in ferritin. Then comes stage 2 of being poor. Stage 2 of being poor is mid-month. Mid-month when you realize not only is my bank account poor, but the money in my hand, I don't have money for, buying maybe an extra pair of clothes or some extra books that I had to buy. So I realized that this is the stage of iron deficient erythropoiesis. Now iron is also going low. As a result, it's affecting my red blood cell. Iron deficient erythropoiesis is getting affected. Basically, I want to make red blood cells, but I don't have iron. I want to buy new books, but I don't have money. So this means over here, the iron profile is deranged. I'll tell you in a while what all is the iron profile. Okay, the entire iron profile is deranged. Now I don't have iron, I don't have transferrin, I don't have all of those iron profile things. Everything is going on. And finally comes stage 3, that is end of the month. End of the month, I declare myself as broke. And that is the stage of iron deficiency anemia. Iron deficiency anemia means what? When I'm saying a stage of iron deficiency anemia, it's microcytic hypochromic anemia. Can I see it under the microscope? Yes. Now you will be able to see microcytic and hypochromic cells under the microscope. So basically now everyone around you can see that this person is so broke. So what are the stages of iron deficiency anemia? First, only your bank balance is low, your ferritin storage is low. Second, then the money in your hand is also less. In the second stage, you can't buy, you can't buy good books and good clothes. This means the iron deficient erythropoiesis has started. And in stage 3, everyone around you in your friends and family can see that you are super broke, because now everyone can see under the microscope that this is microcytic hypochromic anemia. These are the 3 stages. So now when you read this stage and everyone around you can see that this is a case of iron deficiency, what are the clinical features that you are going to see? First and foremost, be it any kind of anemia, patient will always have fatigue, point number 1. Fatigue, tiredness in any anemia will be there. But what are the things which will guide me more towards iron deficiency? You can see this very famous finding of the nails which has been shown over here, and that is koilonychia. Koilonychia is nothing but spoon-shaped nails. Koilonychia is nothing but spoon-shaped nails that are there. Other than that, if you see the angles of their lips, they'll be very, very rough. Angles of the lips. So that is known as angular cheilitis. That is referred to as angular cheilitis, also known as angular stomatitis. That is known as angular cheilitis or stomatitis. What else? In children, you will get a very famous thing known as pica. What is pica? Before I tell the definition. Day-to-day example, mother will say, my child eats mitti, my child eats mud when he goes to play in the park, or my child eats chalk when he goes to school. So basically, eating non-edible items. Pica is nothing but eating non-edible items. That's a very common history also that you get in iron deficiency anemia. And lastly, is there any syndrome with which you associate this? What is the syndrome known as? Plummer-Vinson syndrome. Do you guys remember what was Plummer-Vinson syndrome? I'm doing a very quick recap, although I have taught you everything about Plummer-Vinson syndrome way back in your GIT chapter. Okay, I said GIT, I gave you a very big hint. So Plummer-Vinson syndrome is usually a middle-aged female who comes to you with, obviously, now Plummer and Vinson word is to not telling me anything. Ma'am, can you give me any name that will give me some, cheating ke liye thoda bahut hint hoga? Okay, I'll give you one more name. Plummer-Vinson syndrome is also known as the Patterson-Kelly-Brown syndrome. Patterson-Kelly-Brown syndrome. This is again cheating because I don't get to know anything. These are names of people. What will I get to know? Now I promise I'll tell you a name, and that name is sideropenic dysphagia. This is going to make a lot of sense over here. Tell me guys, what is sidro? Sidro matlab iron. What is penic? Penic matlab deficiency. Here I go. There is a case of iron deficiency anemia in front of me in Plummer-Vinson syndrome. But what was the third word? This was dysphagia. There is difficulty in eating. Why is this patient having dysphagia? Because why did I teach you in GIT chapter? Because the patient is going to have esophageal webs. The patient is going to have esophageal webs. And lastly, guys, so this though is very simple. Siderosplenic told me iron deficiency anemia. Dysphagia told me that there's difficulty in eating because there are esophageal webs. And finally, there is also something known as atrophic glossitis. There is also something known as atrophic glossitis. That is the triad of Plummer-Vinson syndrome, and that is why I told you that Plummer-Vinson syndrome shows you iron deficiency anemia. Let's do a quick recap. Tiredness. Every patient of anemia has tiredness. The fancy things over here are spoon-shaped nails, which is known as koilonychia. The angles of the lips are going to be very rough and excoriated. Angular cheilitis. The mother will say, my child eats non-edible things like mud and chalk, so pica. And then there could be association of a syndrome called Plummer-Vinson syndrome. So this is how a patient comes to you. What are you going to do next? I'm going to do a blood test. I'll first start with the blood test, of course. What do you think you're going to get in the hemoglobin? Of course, it's a case of anemia. Iron deficiency anemia hai. Anemia mein the hemoglobin will be low. Fine. Now you have to tell me the parameters. MCV, MCH, MCHC, RDW. Can you analyze this for me? And one more thing you're forgetting, RBC. अब hemoglobin कम है, तो obviously iron is not there. Think logically, iron is not there. If iron is not there, hemoglobin will not form. RBC count will be low. Common sense. What kind of anemia is iron deficiency anemia? It's a microcytic. Microcytic means MCV will be low. Okay. Next, it's a hypochromic. Hypochromic means the other parameters are also low. MCH is also low. MCHC is also low. Ultimately, I realized no wonder I was giving you that example of being broke. Iron deficiency is a super broke anemia. Everything is less. Hemoglobin, RBC, MCV, MCH, MCHC, सब कुछ कम है. The only rich thing over here is RDW. RDW is increased. Can you recall for me? What was RDW? RDW was telling you variation in size. And isocytosis, RDW is telling you variation in size. Why is there a variation in size? Right now you told me all the cells are chota. Yes. So, most of the cells are chota. Sometimes you will realize that there are some cells which are a little medium, some are a little big, then again chota. So, this is how the smear looks like. So, will you wonder that why is there a variation in size? Because guys, iron is dependent on your diet. Say for 1 week, you were having a good heavy iron diet, your cells were normal in size. Then for 2 weeks, you had an iron deficiency state, your cells have become chota in size. So why is there an increase or a decrease in variation in the size happening? Because this is a nutritional problem. Some days you will have better iron, some days you will not have iron, some days you will have iron tablets, some days you will not. So the nutrition hai, that will keep on going up and down. So the RDW is going to be more. So what did I realize? All the parameters are less. What is more? Hemoglobin, RBC, MCV, MCH, MCHC, everything is less. The only parameter increased is RDW. This was about your basic blood finding. You did this blood report and then you said, I want to look at it under the microscope. What is your rule? Whenever you have to look at it under the microscope, you are going to compare it with what? You are going to compare it with a lymphocyte. Compare the cells with a lymphocyte. Do you see chota cells? So first and foremost, I can analyze that, yeah, they are microcytic. How did you test for the color? How much of pallor was normal, guys? The 1/3 pallor was normal. I can see this has more than 1/3 pallor. Come on, they are almost like empty cells. They are almost like empty looking cells. So can I call them hypochromic? Microcytic, hypochromic. Two things are done. There's microcytic and hypochromic anemia that I have diagnosed. But other than that, I realize some cells are very chota. Some cells are okay, medium type. Some cells are little big type. Is there a variation in size? Am I seeing presence of anisocytosis? Yes, I am seeing a variation in size. What else? I am seeing a pencil cell, a really huge, pencil wala, aisa pencil type of cell over here. So shape is changing, na? And I can see more. This cell is over here is becoming a little elongated. So yeah, I'm seeing some huge changes in the shape also. I am seeing the presence of something known as poikilocytosis. Remember what was variation in size known as? Variation in size is anisocytosis. And what is variation in shape known as? Shape में P था, तो shape is going to be poikilocytosis. And P for which shape am I talking about? Here I am talking about the pencil cells. So I can see a lot of pencil cells that have been marked over here. Now, also note that sometimes the RBC hardly has any hemoglobin. It's looking like a ring. It's looking like a ring. So sometimes you will come across a feature known as a leptocyte, known as a leptocyte or a pessary cell. A leptocyte or a pessary cell is something which is just going to have a thin rim of hemoglobin. It has become so severely deficient. It hardly has any hemoglobin. See, normal kitna tha? Normal should have been this much hemoglobin. How much pallor? 1/3 pallor. Now this hardly has any hemoglobin. It's just like a ring, a tiny rim of hemoglobin. That's it. That's known as a leptocyte or a pessary cell. So think logically, itna problem is happening. Microcytic and hypochromic anemia, anisocytosis and poikilocytosis, pencil cells and leptocytes, everything possible is happening. What do you think the bone marrow should be doing? What do you think should be happening to the retic count? That's a very, very important question that I have at this point of time. What should be happening to the retic count? So you will say, obviously, ma'am, you are in so much of trouble. Your bone marrow should be doing more work. Tell him, do more work, make more reticulocytes for me, help me. How can you make someone work without giving that person food? You are expecting that the bone marrow should work a lot and the bone marrow should give you lots and lots of reticulocytes and all, but you are not giving it any iron. If I don't give you food, how will you function? So is the retic count increased? Is the bone marrow trying to do some work? Yes, but it is not in proportion to the anemia. It is not in proportion to the degree of anemia. I hope we all have understood the meaning of this statement, that reticulocyte is slightly increased because my bone marrow is trying to do the best that he can, but it's not as increased as I thought it should have been because I'm not giving it proper food. That is your entire blood findings. These are your retic count and this is your final peripheral smear for a case of iron deficiency anemia. But even up till now, can you imagine looking at all of this? I never give the diagnosis of iron deficiency because the word tells me that for giving the diagnosis of iron deficiency, I cannot do that without analyzing iron studies. Okay, so what are the different iron studies that you have to know about? Listen to me. First, you measure serum iron. You measure serum iron, measuring the levels. Next, you measure what does iron bind to? Iron binds to transferrin. So next what you measure is transferrin saturation. What we measure next is transferrin saturation. What is the storage form of iron? Storage form of iron is ferritin. Okay. Now, there's another parameter which you call as TIBC. Please note the full form first. Total iron binding capacity. Total iron binding capacity. Okay. Right now, these are your basic things. Then I'll tell you some advanced ones also. Basic में क्या आता है? Iron, transferrin saturation, storage that is ferritin and TIBC. Think logically, you are dealing with a case of iron deficiency anemia. Do you think iron levels will be normal, lower, increased? Of course, iron deficient है तो ma'am, iron deficiency में iron levels will be low. If there is less of iron, no one will bind to transferrin. Transferrin saturation will also be low. If there is no iron, then bank account may be no savings. Nothing is going to be there. Full poor broke person, no iron, no saturation, no ferritin, no transport, no storage, nothing. Now, when you have no food in your system, and even if I give you one piece of chocolate or one toffee, you are going to like grab onto it and eat it. When you have no iron in your system, what do you think is your hunger? Total iron binding capacity. You will say, ma'am, my hunger is 100%. So the only thing that has increased is TIBC. The total iron binding capacity is a lot. So think logically. When there is no food in the body, of course, the hunger for the food is going to be very high. Total iron binding capacity is very high. Next, if I ask you, why am I always talking about iron? Because you will say, ma'am, I want to make hemoglobin. So simple concept, I need iron. Iron combines with what to make hemoglobin? Taking you into biochemistry. Iron combines with what? Iron combines with protoporphyrin. Iron combines with protoporphyrin. So think logically, when iron is only not there and hemoglobin production is going to go down, Who is standing free in the system? Forever single. Protoporphyrin is forever single. Protoporphyrin says, I had to partnership with iron, my partner has not come, so I am forever single. So if they ask you what is free erythrocyte protoporphyrin levels going to be, repeating, if they ask you what are the levels of free erythrocyte protoporphyrin, these are going to be increased because protoporphyrin has become forever single. Protoporphyrin says, I am forever single, there is no iron in my life, so I will now just keep waiting and I'm waiting for iron to come one day. So what did I realize? All the parameters decrease. The only two parameters that increase are going to be TIBC and FEP. Similarly, in the previous one, all the parameters were decreasing and the only parameter that was increasing was going to be RDW. That is how you learn iron deficiency ka blood parameters. Done with this. What do we have to know further? Many students also keep asking me the normal values. So let's finish those. Iron ka normal value you have to know. Then you have to know how much iron will bind to transferrin, which you already know, and you need to know TIBC ka normal value. Iron is somewhere around 50 to 150 microgram per deciliter. Average कितना है? Easy याद करते हैं ना, 100. I have to have 100 molecules of iron. ठीक है? 100 into 3 कर दो. 100 into 3 कर दो. That is your iron binding capacity. So what is TIBC? TIBC is usually, this is just a very quick way of learning. Iron into 3 is going to be total iron binding capacity. So if I take the iron to be 100, then the total iron binding capacity somewhere comes around 300 microgram per deciliter. And finally, what is transferrin saturation? Remember that formula I told you, 2/6 wala formula I told you, transferrin saturation is 33%. We take it somewhere between 15 to 50%. This is a very big range because you have to study it in so many people, India, abroad, male, female. But for all practical purposes, we consider it somewhere to be around an average of 33%. Repeating, I have learnt it in a simple way. Iron ko to I have learnt as 100. And 100 into 3 kara, so I got my TIBC, so TIBC ho gaya 300 and transferrin saturation is 33%. So 100, 300 and 33%, I like to learn it like this. Rest, I'm sure you will also like to learn it like this. Okay, moving on. Now I want to do a kind of a, many students ask me what is better, what is not. So nowadays, they are saying that there is something known as a serum transferrin receptor divided by log of ferritin. This is something that they are trying to calculate. Having discussed all the peripheral smear, blood findings and iron studies, we are ready for discussing the bone marrow studies. Now guys, bone marrow is something which we don't usually do for an iron deficiency anemia for obvious reasons being that bone marrow is not needed. It's a very invasive procedure. It's a painful procedure. For something as simple as iron deficiency, I can definitely do without a bone marrow. But if it is done, what would I be seeing? You will see the regular red blood cell precursors. You will see the normoblasts. But tell me, when the red blood cells, the mature cells were chota, microcytic, what do you think the precursors are going to be? They are also going to be chota. So that are going to be micronormoblasts. That is what we see. We see the presence of micronormoblasts that are present in the bone marrow. Point number 1. Point number 2. I want to test for iron. What stain should I use? This I've been asking you a million times since the beginning of pathology. The stain that we use is the pearl stain or the Prussian blue stain. And how much of iron will I get? I will get grade 0. Grade 0 means that there is no iron in the stores. Let me tell you, this happens to be the gold standard, the most specific test that we have for testing of iron deficiency. The gold standard, although no one does it. It's very painful, very expensive, very invasive, not at all practical to do. No one does it. But in my MCQs, the most specific is that you find out directly that iron is not there. That is the most specific test that you have. Okay, lastly, I need to tell you what is the treatment, which I think everyone knows. The treatment of iron deficiency anemia shall definitely remain iron supplementation, and also you have to treat the cause. You have to treat the cause as well, whatever is the underlying cause, be it blood loss, be it a diet, be it the demand, whatever is the underlying etiology you have to treat. But please remember, when would you follow up a patient? You will follow up a patient first. What will you do? Patient comes to you. You do his tests. You find out he has iron deficiency. deficiency. You give him iron supplementation and then you say that come after 7 days. Follow-up has to happen after 1 week or 7 days. What are you going to do in a follow-up? In a follow-up, you are going to basically find out reticulocyte count. You are going to basically find out about the reticulocyte count, because if the reticulocyte count is going to be more, you'll be like, okay, the bone marrow is responding, everything's going fine, iron is doing good for the patient. So on 7 days, you call the patient for a blood test and you find out that if there's an increase in the bone marrow response, that is, there's an increase in the reticulocyte count, then the patient is doing super duper well. That is all that you had to know regarding iron deficiency anemia. This was the first anemia that you studied under microcytic hypochromic. What is that? Seta mnemonic. So iron is done. Now I'm going to go on and talk about the A in it, and that is the next one, known as anemia of chronic disease, which is written as AOCD. Now, please note, in AOCD, as I told you earlier, it is predominantly a normocytic normochromic anemia, and then it can also be a microcytic hypochromic anemia. But before I get into this, let me tell you the pathogenesis. When I say anemia of chronic disease, of course, the word chronic tells me that there will be some kind of a long-term disorder that would be mentioned. For example, it could be a case of rheumatoid arthritis. It's definitely a long-term, and that's one of the most common etiologies and the common questions or clinical histories that you get. So it's going to be a case of rheumatoid arthritis. And whenever any chronic disease happens, what is the interleukin that is going to increase? There is going to be an increase in interleukin, especially interleukin 6 increases in the body. And whenever interleukin 6 increases, it goes and acts on the liver and it makes it release a molecule referred to as hepcidin. So let's repeat, whenever there is any chronic disease like rheumatoid arthritis or any other disease, there is going to be an increase in interleukin 6, which will go and act on the liver and will result in the increase of a molecule known as hepcidin. Have I already taught you what is hepcidin? Wasn't hepcidin the mastermind or the master regulator, the hijacker? What did it do? What will it allow? Will it allow you to absorb any iron? No, it was an inhibitor, hijacker. So like we said, it inhibits iron absorption. It is going to inhibit iron absorption. So what is going to happen in this person? The person is eating good food, good iron, but not absorbing it. What do you think will happen to the serum iron levels? The serum iron levels will go down. If the serum iron levels will go down, what will happen to the transferrin saturation? That will also go down. No iron, nothing to bind to transferrin. Transferrin saturation also goes down. Then you say that, okay, there's no iron, there's no one binding to transferrin. Let me take iron from my bank account. What is the bank account? Bank account is like ferritin. So does hepcidin allow you to take money from your bank account? Hijacker will never let you take money from your bank account. So hepcidin will inhibit that as well. It inhibits the release. It inhibits the release of iron from ferritin. So even your bank accounts have been frozen. There is no release of iron from ferritin. So there's a money in your bank account. You're very, very rich in your bank account. So your ferritin is very high. You have a lot of money in your bank account, but no one is letting you use that money. So like I used to tell you, iron all around. There's so much of iron in the food, but you cannot use it. There is so much of iron in your bank account, but you cannot use it. So I realized that because I can't absorb it, I don't have any iron, I don't have any transferrin, and because I can't use my bank account has a lot of iron. So now tell me, if you have a person who is showing off that he doesn't have any money, he doesn't have any iron, but his bank account is loaded, he is multi-millionaire when it comes to his bank account, what do you think will happen to his total iron binding capacity? For example, if I say you have 100 million in your bank account, would you want to wake up tomorrow morning and study for NEET or FMG? No, you will become a little chilled out in life. Same way, if I know that I have too much money and too much iron in my bank account, my capacity automatically decreases. The total iron binding capacity. The total iron binding capacity is definitely going to go down. It is going to be down. So now if I ask you, what is the profile of anemia of chronic disease and how does it vary and differ from iron deficiency anemia? So this is one of my favorite stories. I always tell students the difference between a real beggar and a Dilli wala pseudo beggar. So real beggar is what? Real beggar is someone who's genuinely poor. He genuinely has no money in his hands. He has no money at home. He has no money in his bank account. So if I ask you what is his iron levels, you'll say no iron. Transferrin saturation, no iron to bind to transferrin. Bank account, again, no iron. So he would obviously be very, very, very hungry. His TIBC will be more. But now if I tell you a Dilli wala, pseudo beggar, he is showing everyone that, oh, listen, I don't have any money and I don't have any transference saturation. Please give me some money. But if you go to his house, he's richer than all of us. He has better homes than all of us. If you go to his bank account, he is loaded with money. And because he is loaded with money, of course, his ability to bind to iron is going to be less. So remember, this is the real wala beggar. This is the real wala beggar, and this is going to be the pseudo beggar who is just showing you that he doesn't have any money, but he has a lot of money in his bank account. So ultimately, if you had to differentiate, so I always tell students, whenever you get confused between iron deficiency anemia and anemia of chronic disease, kahan chapa lagana? Bank account pe chapa lagana. If you find out that the bank account is genuinely poor, to matlab really poor person, iron deficiency anemia. But if the bank account has a lot of money, this is pseudo beggar. This is pseudo beggar. I have put a raid on his bank account and found out that his bank account has a lot of money, ferritin is there, and that is why he's anemia of chronic disease. Next difference, TIBC. If you forget in the paper whose TIBC was low and whose TIBC was high, you can learn it as this mnemonic itself. TIBC, total iron binding capacity, is learned as top in iron deficiency anemia and bottom in chronic disease. Top in iron deficiency anemia and bottom in chronic disease. That is what you need to know about TIBC. Repeating, top in iron deficiency anemia and bottom in chronic disease. Again, top in iron deficiency anemia, bottom in chronic disease. That is how you differentiate between them. But nowadays, guys, there are some other parameters which they are using, and there's a new parameter that has come up which I want to share with all of you, and that parameter is serum transferrin receptor divided by log of ferritin. Pehle to please tell me, if I have to differentiate, what is ferritin? Ferritin is the bank account. If I have to differentiate iron deficiency anemia and anemia of chronic disease, whose bank account has a lot of money, obviously the ferritin is going to be, the bank account is going to be very, very rich in case of this anemia of chronic disease. The bank account has a lot of money over here. So when the denominator is going to be very, very high, the overall ratio will be less. So serum transferrin receptor divided by log of ferritin will be less than 1.5 in anemia of chronic disease. Whereas in a case of iron deficiency anemia, bank account is genuinely very, very poor. Bank account is genuinely very poor. This means the ferritin levels are genuinely very, very low. The denominator is very low. This means the overall ratio is going to be more than 1.5. So there's another difference. Again, I'm repeating. If they ask you what is serum transferrin receptor divided by log of ferritin, the concept of the bank account still remains. Ferritin was very, very high in anemia of chronic disease, so the overall ratio becomes low over here, and it is more than 1.5 in iron deficiency anemia. That sorts out our anemia of chronic disease. The last question that they'll ask you, what do you do for the treatment of anemia of chronic disease? Please note, it's not about treating iron deficiency. The primary treatment is treatment of the underlying cause. You had to treat rheumatoid arthritis. You had to treat whatever chronic disease is there. So treat the underlying cause, and that is important. We were doing the mnemonic Sita. So we are done with anemia of chronic disease. We are done with iron deficiency. We are left with the last one, and that is sideroblastic anemia. Before I start with sideroblastic anemia, you will suddenly realize that this is an anemia, of course. Blast means some precursor they must be talking about. Sidro means iron. Now this is also to do with iron. Ab iron deficiency hota, so I would have called it iron deficiency. This must be the other way around. This must be iron overload. So up till now, I did iron deficiency anemia, where iron was low. Now I'm going to do the complete opposite, and that is sideroblastic anemia, where iron is going to be very, very high. So now I want to tell you, why is iron high? For that, I will ask you something from biochem. I know you don't like it, but you will have to study it. What is biochemistry? Heme formation. Because I know that hemoglobin is equal to heme as well as globin, right? So now I'm talking about only the heme part. Who makes the heme part? Let me make it right in the end. Heme is made up of two aspects. Heme is made up of iron, and heme is made up of a ring called protoporphyrin. Heme is made up of iron and protoporphyrin, and when they fuse, where does this reaction occur? Iron and protoporphyrin fuse where? They fuse in the mitochondria. They fuse in the mitochondria, and which is the enzyme that helps in their fusion? The enzyme is known as ferrochelatase. The enzyme is known as ferrochelatase. So remember, How is heme formed? Where iron and protoporphyrin come in the mitochondria in the presence of ferrochelatase, they make heme. But how did this protoporphyrin come? The protoporphyrin story starts from succinyl coenzyme A. I think everyone knows succinyl coenzyme A forms ALA. ALA by the process of what? ALA by the process of ALA synthase. That ALA synthase is then going to form the very famous porphobilinogen. Porphobilinogen is going to be formed by ALA dehydratase. It is formed by ALA dehydratase, and finally by a series of steps I will have protoporphyrin. So repeating once again, ALA is the enzyme, ALA synthase, ALA dehydratase. So basically I want to say that I need ALA synthase for the production of protoporphyrin, I need ALA dehydratase for the production, and after that further for the production of heme I also need ferrochelatase. This means if at any point of time anything in this entire pathway goes wrong, other than iron ka story I'm not talking about, anything other than iron goes wrong, that is referred to as sideroblastic anemia. So simple. If iron would not have been there, I would have called it iron deficiency anemia. But if anything else in this pathway goes wrong, then I'm going to call it sideroblastic anemia. So now tell me one thing. If it was a case of iron deficiency anemia, iron was not there, then who was forever single and whose levels were more? Protoporphyrin levels were more, if you remember. In this situation, I'm saying that all these conditions, all these things are not there. For whatever enzyme deficiency, all these things are not there. Now, who is going to be forever single? Iron is going to be forever single, so iron levels are going to go up. So that is exactly what I'm going to study. What are the causes of sideroblastic anemia? Either we can have something called congenital causes, or we can have acquired causes. Congenital or acquired causes. So congenital causes are to do with enzyme deficiency. Congenital causes are to do with enzyme deficiency. Which enzyme deficiency? All the enzymes that I just spoke about, ALA synthase, ALA dehydratase, ferrochelatase, all of those enzyme deficiencies are to do with congenital causes. But did you notice that is there any cofactor that you need? For the functioning of all these enzymes, I need a cofactor called vitamin B6. So if I have an acquired cause and I say that there is a vitamin B6 deficiency, which can be seen with which drug? For example, with isoniazid. With isoniazid, you can see vitamin B6 deficiency, right? So then also this process will not occur. Or in other words, you say that what if you have a patient of lead poisoning? Lead poisoning also does not allow. For example, another poisoning, that is alcohol poisoning. Alcohol poisoning, why? Because alcohol is also a mitochondrial poison. Alcohol is something that poisons the mitochondria. That is what alcohol does. So remember, if there is lead poisoning, if there is alcohol poisoning, whatever may be the situation, the patient will land up with sideroblastic anemia, which means what? What is not being formed? The protoporphyrin ring is not being formed. The protoporphyrin ring is not being formed, and this iron is left forever alone. So iron is too much and there is no one to combine with. So iron is left forever alone. How will that iron look like? You will say, first show me a peripheral smear. On a peripheral smear, because there is so much of iron that is referred to as iron aggregates, they look like these bodies. Can you appreciate? In this red blood cell, you are seeing lots and lots of bodies. What are these bodies? These are the famous Pappenheimer bodies. These are referred to as the Pappenheimer bodies, and they are made up of iron. You don't trust me? You want to prove that? How would you prove that? These Pappenheimer bodies will now be known as what stain? I will stain it with pearls or Prussian blue. If you want to prove that this is definitely made up of iron, you will use pearls or Prussian blue staining. So please remember that Pappenheimer bodies, are they single or multiple? They are multiple bodies that you are noticing. They are multiple bodies that you notice, and these multiple bodies are going to be responsible for the Pappenheimer, the iron aggregates, and if I want to prove them, I am going to basically go ahead with pearls or Prussian blue. On that note, this is all that you were seeing on a peripheral smear, but what is happening way back in the bone marrow? What is happening way back in the bone marrow? Please remember, in the bone marrow, you will see something known as ringed sideroblasts. Very interesting concept that I'm going to tell you. When I say ringed sideroblasts, first I want all of you to notice the word. I'm saying blasts because in bone marrow I have precursors, na? And do blasts have a nucleus? Yes. So I'm going to draw a cell over here. And in that cell, I'm definitely going to draw a nucleus because all the blasts have a nucleus. So here you have the nucleus of an erythroblast. Some blast is there. Why did I say sidro? Sidro matlab iron will deposit here. Also, there's so much of iron in the body now that iron is going to deposit here. So here I will see iron is getting deposited. But where is iron getting deposited? Iron is getting deposited in this perinuclear location. Why? You will ask me, why, ma'am? Why is iron getting deposited in this perinuclear location? I want to take you all the way back. Can you tell me? This iron and protoporphyrin, initially when I thought that I will make a relationship out of iron and protoporphyrin, where were they planning to meet? They were planning to meet in mitochondria, right? Now protoporphyrin ne ditch kiya. Protoporphyrin, for whatever reason, protoporphyrin did not come. So where is iron sitting now? Where is iron sitting and waiting for the protoporphyrin to come? Iron is sitting in the mitochondria and waiting and praying to God, one day my partner will come. So do you know where is all the mitochondria present? All the mitochondria is usually present in the perinuclear region. Mitochondria abundance in a cell is usually in the perinuclear region. So now you understand why is there iron in the perinuclear region, because iron is present in the mitochondria and mitochondria is always perinuclear in abundance. Please note. And has it made an entire ring around it? Yes, and that is known as ringed sideroblasts. So what is the stain that I must have used in order to prove iron? Again, I always use the rings, the pearls or the Prussian blue stain, and can we see the blue granules making a ring everywhere? But somewhere it is making like a proper ring, somewhere it is making half a ring, 1/4 of a ring. How much of a ring is said to be a ring? What is the criteria? So please remember, ringed sideroblast is said when there are at least 5 granules of iron and they have covered at least 1/3 of the nucleus. Means, let me draw it once again. At least there are 5 granules and they have covered 1/3 of the nucleus. So if there is 1, 2, 3, 4, 5, and over here more than half only has been covered. So even if I have 5 granules and 1/3 of the nucleus is covered, I will call this also a ringed sideroblast. So please note, ringed sideroblasts are seen in which two conditions? Number one, it is seen in common sense. Sideroblast will be seen in sideroblastic anemia. Where else once more will I talk about it? I will talk about it in myelodysplastic syndrome when we go further and study the last part of the WBC chapter. Please refer, I have told you, myelodysplastic syndrome shows a mutation called SF3B1 mutation. And SF3B1 mutation is associated with ringed sideroblast. This information is important only for the higher institute exams like for INI, CET and so on. These are the two situations in which you see ringed sideroblast. So coming all the way back now, you've seen Pappenheimer bodies were made up of iron. That was seen in a peripheral smear. Ringed sideroblasts are seen in bone marrow. What do you see on blood testing? Common sense. Too much of iron means the serum iron levels are going to be very, very high. If the serum iron levels are very, very high, then the transferrin saturation shall be very, very high. And if the transferrin saturation is high, then the bank account is also going to have everywhere iron everywhere. Abundance of iron. Too much of money, really rich person, Ambani, having money all around, money in the hand, money in transferrin, money in the bank account, everywhere. So what is the total iron binding capacity? When you have so much of money, why do you want more money? You don't want more money. The total iron binding capacity becomes less. Finally, on that note, can I make a final flowchart of how to differentiate iron deficiency anemia, anemia of chronic disease and sideroblastic anemia? First, let me give them their pet names. Iron deficiency anemia was the real beggar, where everything is going to be very, very less. Sideroblastic anemia is the Ambani, where everything is like too much, overload. And anemia of chronic disease is that pseudo, that liar who's lying to me because I will catch him by his bank account. So what do I mean when I say iron deficiency anemia? Iron is less, transferrin saturation is less, ferritin is also less, and TIBC is high, the capacity is high. So this was the real beggar, where everything was less and the hunger was more. Whereas when I go to the Ambani of the family, everything is more, iron is more, transferrin saturation is more, ferritin is more, therefore the hunger is less. So दोनों opposite है, एक deficient है, एक overload है, simple. Coming to the AOCD, the real deadly one, shows I have no money and no saturation, but when I go to his bank account, ferritin and bank account is loaded. So if he has too much of money in his bank account, obviously he will not have any capacity to bind to iron. That is your final story that you had to know for IDA, anemia of chronic disease, and sideroblastic anemia. So can I say that our mnemonic that we were talking about, we said Sita, many students learn Sheetal also. I don't like Sheetal because L is for lead poisoning, and I've already told you that lead poisoning comes under sideroblastic anemia only. So why study it separately? So sideroblastic anemia done, iron deficiency anemia done, anemia of chronic disease also over. Thalassemia I have not covered here because thalassemia is a hemoglobinopathy which I'll be covering under the hemolytic anemias. So for the time being, microcytic hypochromic anemias are done and we are ready for some questions. Let's start from the beginning and go ahead. Let's start with question number 1. There's a 43-year-old Caucasian female who has reduced energy and fatigue and is found to have microcytic hypochromic anemia. Her past medical history is significant for stable angina treated with metoprolol and aspirin. Iron supplementation is prescribed. Several weeks later, a peripheral blood smear demonstrates enlarged red blood cells which are blue. Do you remember that what were the cells which were big and blue on a right Giemsa stain? Right Giemsa stain means Romanovsky stains. These were the polychromatophil. What is the other name of polychromatophil? The other name was the reticulocyte. Big blue cells were reticulocyte. They are asking you what is the bluish color of these cells because of what is reticulocyte made up of? RRR. Reticulocyte is made up of ribosomal RNA, and that's the answer over here. There should not be any confusion in this question. Moving on to the next question. This is a nice one. Here you have a 38-year-old patient or a man who presents to the emergency department due to severe alcohol intoxication. A patient is agitated, refuses to answer any questions in regards to his medical history. Vital signs are normal. Complete blood count shows hemoglobin is slightly on the lower side, 11.5, hematocrit slightly okay. MCV 77. So first and foremost, normal MCV was 80 to 100. 77 means I'm dealing with a microcytic condition. As soon as I say microcytic condition, I have to think of Sita mnemonic, right? Using a special dye, blue colored dots are seen in the peripheral smear with blue color rings. Blue dots, blue color rings. Which blue color special dye can I use? They must have used pearls or Prussian blue. There is no other blue color special dye that I know of. And they are saying lots of bodies and rings are seen. Are they trying to tell me about Pappenheimer bodies? Let me see. Let me first read. What are they saying? If you are based on this, what are the most likely findings in ferritin, TIBC and iron levels? So, because firstly, I am thinking of pearls or Prussian blue and Pappenheimer bodies means iron zyada hai. And that has further been implicated by alcohol intoxication, because does alcohol intoxication result in sideroblastic anemia? Yes. What do you expect the iron to be in sideroblastic anemia? You expect it to be high. What is the bank account? That is also going to be high. And what is the overall capacity? The overall capacity is going to be low. So what is the final answer over here? Option number C. Sideroblastic iron overload. We have managed to finish our discussion of all the microcytic hypochromic anemias with the questions, and we are ready to now take on our journey for the macrocytic anemias.